my name is Dr. Mike Murphy, and I'm one of the founding faculty of the Difficult Airway course, Emergency Anesthesia and EMS. For some years, in order to demonstrate the anatomy that we actually use when we're manipulating airways, I've been doing a self-scope at many of the courses for emergency and anesthesia. And we videotaped the self-scope so that we can use it in other teachings. So what I'm going to do right now is I'm going to put this fiber optic bronchoscope through my nose and show you some structures of the upper airway that you will encounter as you do airway management. I've pre-topicalized my nose with 4% lidocaine and an aqueous solution using a mucosal atomization device. So just come with me and we'll take you for a tour of the airway. I've been holding onto the scope for a little while in order to warm it up, because by warming it up, I'm able to minimize the amount of fogging. As I come through the back of my nose, you can see my soft palate rise and fall. And then you can see a pit. And that pit, which is cherry red, which is to the right of the screen in the center, is the area where the eustachian tube comes down from my right ear into the back of my nostril. Arching over top of that eustachian tube opening is lymphoid tissue called the adenoid or the nasal tonsil. Now the nasal tonsil or adenoid, the fascial tonsil is the back of your throat, and the lingual tonsil at the base of your tongue form a structure known as Waldeyer's ring, which is a protective ring of lymphoid tissue in the upper airway. As I said to you before, you could see my soft palate rising and falling, and what we're going to do is we're actually going to go over back of my soft palate and down into my upper airway. And as we come over the back of my soft palate, you can see looming up in front of you my epiglottis. Now what I'm going to do is I'm going to turn the scope 180 degrees so that you can actually see it in the orientation that you're used to seeing it in. Like that. So there is my epiglottis, which you can see clearly in the middle of the screen. In the front you can see the back of my tongue, and on the base of my tongue you can see that it's rather marbled in appearance, and that marbled appearance is the lingual tonsil. As I stop talking, you'll see a structure lay on the back of the tongue, and that's the uvula of my soft palate. Now the epiglottis that you see here is somewhat abnormal in shape. It's longer in the right limb than it is in the left, and that isn't normal. However, it is V-shaped like the normal adult epiglottis. One of the ENT surgeons that I worked with one time looked at my epiglottis and wondered if I'd had epiglottitis as a child, and since I'm still alive, I don't think that actually occurred. Now, in front of the epiglottis, and back of the base of the tongue, between those two structures, is something called the vallecula. And the vallecula is an important structure. There's a right-sided vallecula and a left-sided vallecula. The vallecula contains structures that course onto the epiglottis in the airway, and the neurovascular bundle that goes through the vallecula produces sensation or delivers sensation to the epiglottis. The superior laryngeal branch of the vagus supplies the nerve on either side that supplies sensation to all of the glottis above the level of the vocal cords. I'm going to swallow. Now, what I'm going to do is protrude my tongue, and I'll show you the vallecula on the right-hand side and attempt to point out the neurovascular bundle that you'll see coursing through it. And now I'll show you the neurovascular bundle on the left side. So you can see it's fairly easy to maneuver your way around the upper airway. Next, what I'm going to show you is a structure known as the glossoepiglottic fold. The glossoepiglottic fold goes from the base of the tongue to the epiglottis, and it is actually covering a structure known as the hyoepiglottic ligament. The hyoepiglottic ligament is the structure that you depress with the blunt tip of the curved blade to flip the epiglottis up so that you can visualize the opening through the cords to put your endotracheal tube in. So let me come down now in the midline and we'll show you that glossoepiglottic fold covering the hyoepiglottic ligament. And it's a robust and very strong structure. Now, as I come down in back of the epiglottis, you can see my vocal apparatus. You can see my vocal cords open and close. In the back of the vocal apparatus, what you see swinging in and out are actually my arytenoid cartilages. Those arytenoid cartilages actually move the vocal cords open and closed so that you can phonate. Then what I do is, in order to change the pitch of my voice, my thyroid cartilage tips forward and back on my cricoid ring in order to tense the vocal cords and increase the pitch of my voice, like this. Now, as I come down inside the glottis, what you can see is the false vocal cords sitting on top of the true vocal cords. When someone has laryngospasm, what happens is that both of those structures become tightly opposed, and by simply gently pushing the tip of the endotracheal tube between the false and true cords, you can intubate a patient who has laryngospasm. So let me take you down and we'll show you the true cords and the false cords. And then as you look beyond the vocal cords, what you can see is the upper portion of my trachea. You can see the cricoid ring anteriorly, the cricothyroid membrane, and then as you look beyond that, you can see tracheal rings. So let me take you down and show you that. Now what I'm going to do is show you the piriform recess on either side. As I stand here without swallowing, my glottis actually sits in the back of my hypopharynx, and it produces a passageway into the esophagus on either side of the airway called the piriform recess. When I swallow, the intrinsic muscles of swallowing elevate the voice box, flip the epiglottis down over top of the airway, and the food bolus goes down right in the midline behind the vocal apparatus into the esophagus. Sometimes fish bones get stuck in the vallecula, or they get stuck in the piriform recess, and if you're doing a diagnostic scope, this is where you have a look. Here's a right piriform recess, and you can see that there's actually a neurovascular bundle there, and that neurovascular bundle is also transmitting branches from the superior laryngeal branch of the vagus to the voice box for sensation. And here is the left piriform recess. So if you put a nasogastric tube in the right nostril, it typically goes down the left piriform recess. If you put it in the left nostril, it typically goes down to the right. So that concludes the anatomy lesson. So on the way out, what I'll show you is the right piriform recess, the left piriform recess, the arytenoid cartilages swinging in and out as I speak. Between them, the interarytenoid fold, the aryepiglottic fold from the arytenoid cartilages to the epiglottis, the vocal cords between the two arytenoids, the false cords on top of the true cords, the epiglottis, in front of the epiglottis, the hyoepiglottic ligament with the glossoepiglottic fold, the right and left follicula with their neurovascular bundles, the lingual tonsil, the uvula sitting on the base of my tongue, and as I come up into the nose, what you can see is that pit where the eustachian tube enters the back of my nose, the adenoid in a horseshoe shape above it. You can see that my soft palate now above us is rising and falling as I speak, and we're done.